I am going to continue with my somewhat longer form content, pulling from the scholarly literature, but I wanted to first offer a summary of the videos I have been putting together thus far on the mental health industry. I discussed the following points in greater detail in those previous videos, again, to reiterate in relation to the professional and academic literature. These points are not just my opinion. The Diagnostic and Statistical Manual of Mental Disorders, DSM, published by the American Psychiatric Association, is the primary handbook used to diagnose and classify mental disorders. It is not just used by mental health professionals, but is also used by social workers, health insurance companies, regulation agencies, pharmaceutical companies, the legal system, and policymakers. Although the problems defined in the DSM are claimed to be medical, they have no biological markers or known sets of causes or etiology. If such markers or causes for one of the disorders listed in the DSM are discovered, that disorder is subsequently removed from the manual. This handling of what are supposedly medical diseases or illnesses highlights the over 60-year argument from the likes of psychiatrist Thomas Szasz that the whole mental illness terminology itself is nothing short of an inadequate metaphor. I would also add, this does not mean that people do not have any emotional or mental struggles. Such problems can be very real, but the idea that they are diseases and that the mental health industry is adequately equipped to treat them in any medical fashion falls short of reality. And more on treatment in a moment. The DSM-1 and DSM-2 provided a classification scheme of mental disorders, with only some general diagnostic criteria listed. It was the task force for the DSM-3 which developed explicit symptomatic criteria for the diagnosis of each mental disorder. While work began on this edition in 1974, during an era when psychiatry was becoming increasingly unpopular and the very validity of psychiatric diagnosis was questioned, its task force pointed to the reliability of diagnosis, the extent to which clinicians can agree on the same diagnoses, as the central issue facing psychiatry. At publication in 1980, the DSM-3 was presented as having solved that problem of reliability. Prominent psychiatrists and many others from the mental health industry fell in line with this messaging. However, even under significantly controlled conditions which would produce far better numbers than any normal clinical settings, researchers found that reliability was only slightly improved with this third edition of the manual.
Hello, my name is Dr. Alan Francis.
Nevertheless, even decades later, psychiatrists, even those critical of later editions, have praised the DSM-3 as having revolutionized psychiatry, or even as having saved psychiatry from irrelevance. Some have also claimed it marked psychiatry's move away from psychodynamics towards hard science. Psychodynamics meaning the ideas surrounding unconscious processes and unresolved past conflicts as popularized by Sigmund Freud and others. All this because of the way the DSM-3 addressed the problem of reliability. Despite these claims, however, beyond the reliability problem persisting, the third edition of the manual was developed by expert committee rather than any scientific methodology. And when conflicts emerged, the loudest experts got their way. The task force for the DSM-4 acknowledged the serious scientific shortcomings of this development process, and in turn presented these shortcomings as a problem they would solve by taking a conservative approach, or rather, by not making many changes in their edition at all. Taking a step back, the same year work was underway on the DSM-3, 1974, the APA began pursuing an economic relationship with the pharmaceutical companies. While it is unclear how this relationship might have impacted the third edition, a known 56% of the DSM-4 panel members, the individuals who serve in specialized groups tasked with making the revisions, had financial conflicts of interest ties to pharma. This number increased to 58% for DSM-5 panel members. Most importantly, the panels with the highest number of members with financial conflicts of interests were those for which pharmacological treatment is the first-line intervention. Even the head of the task force for the DSM-3 and the head of the task force for the DSM-4 have been significantly critical of the DSM-5. They and many other psychiatrists and mental health professionals believe this most recent edition of the DSM has allowed normal suffering to be diagnosed as pathological. They specifically highlight as well the harm that DSM labels can cause. In this context, you can find serious criticism of pharmacological interventions. Psychiatrists and others point especially to the chemical imbalance theory of mental disorders as a myth here. They also blame the rampant diagnostic inflation and hyperinflation in relation to the DSM-5 on such changes as the removal of the bereavement exclusion for major depressive disorder. The bereavement exclusion was included in the DSM-3 and DSM-4. It noted that bereavement could be a potential contextualizing factor as to why an individual might experience major depressive symptoms, and more importantly, it noted bereavement as a reason to withhold a diagnosis of major depressive disorder. This exclusion was removed from the DSM-5 with the justification that the clinician should consider giving someone who is bereaved and experiencing symptoms of the disorder the diagnosis anyway. However, this criticism of the DSM-5 is incredibly hypocritical given how significantly the bereavement exclusion is, or rather was, qualified in the DSM-3 and the DSM-4. If the bereavement is complicated or is associated with marked functional impairment, both editions insist a diagnosis should be given anyway. The symptoms for this supposed illness or disease are the following: depressed mood, markedly diminished interest or pleasure in activities, significant weight loss or weight gain, insomnia or hypersomnia, psychomotor issues, that is, nervous or intense movement or slowed movement, fatigue or loss of energy, feelings of worthlessness or guilt, diminished ability to think, recurrent thoughts of death. Given these symptoms, and that the only acceptable context listed for these symptoms in the DSM-3, 4, or 5 is uncomplicated bereavement, at best it reveals how arbitrary the mental health industry's distinction is between who is abnormal or diseased and who is healthy. Psychiatrists will talk out of both sides of their mouth on this issue as well, insisting that there are many normal reasons for a person to experience these symptoms, while also maintaining that strict adherence should be kept to this uncomplicated criteria. Life is not always uncomplicated, and complication is no justification to just go ahead and attach a potentially harmful label to someone. Moreover, the continual revision process of the DSM and its diagnoses are a facade. The claim that the DSM-3 revolutionized psychiatry by solving the problem of reliability is wildly inaccurate. The third edition of the manual may have improved on the reliability issue, but only slightly. The justifications given for subsequent revisions also fall short of the mark, and only appear to be excuses to keep the revision process going or to otherwise expand the scope of mental disorder to include broad swaths of normal behavior and thinking. Concerning treatment, I did not spend much time on pharmacological prescriptions as of yet, only emphasizing comments from psychiatrists and social workers about the falsity of the chemical imbalance theory of mental disorders, and how powerful these interventions are for people who may in fact simply be reacting normally to abnormal life circumstances. However, I did discuss psychotherapy at length. Despite the mental industry call for everyone to see a therapist, therapy is not harmless. The very way the industry is known to discourage the individual from talking with family, friends, or loved ones about everyday issues, with the reasoning that someone's family, friends, or loved ones may be biased or be suffering from mental health issues themselves. Doing this to try and pull someone into therapy is itself a therapeutic harm. Proper therapy would focus on strengthening a client's existing social support systems rather than trying to break them down. In addition, there are many reasons that can lead a therapist or their client to believe an ineffective or even harmful treatment is effective. This is why you should be careful either receiving or giving the advice, "You should go see a therapist because therapy helped me." People are also encouraged to begin therapy based on the idea that the therapist is better equipped than an individual's family, friends, or loved ones to be empathetic. However, empathy is not something that can be taught directly. And while mental health professionals consistently like to present themselves as especially warm and caring listeners, this has little to do with what the therapist or clinician does in practice. Cognitive behavioral therapy, CBT, the most popular form of therapy, for instance, is specifically designed to challenge negative thoughts and dysfunctional beliefs and change behavioral patterns, not to empathize with them. Almost 80% of therapists self-report to ascribing, at least in part, to CBT methodology. While researchers present CBT as the most empirically based form of therapeutic treatment, in some cases, even in comparison to pharmacological interventions, the studies that support it are often weak or low quality. When the cognitive and behavioral components of CBT are studied more specifically, the results undermine the idea that thoughts must be challenged in therapy. By being fixated on the problems in the here and now, CBT often does not allow for addressing a client's broader underlying issues. Generally speaking, the mental health professional is capable of serious controlling and manipulative behavior and of harming their clients or patients in deeply impactful ways through such behavior. These are issues some within the profession are willing to address directly, but it will always come with the caveat that you, as a non-professional, should not be too critical. The bottom line is, the more you dig into the mental health industry, the more you should realize that it is not the place you would want to send the people you care about for help, especially not as a first resort. This is one of the many reasons why we should be able to rely on each other as human beings. And I will leave it off there until next time, returning once again to the scholarly literature. I hope to see you there.